Good evening and welcome to the Immunisation Coalition webinar. Our topic is human papillomavirus disease, a 2026 update. I'm Andrew Baird. I'll be your moderator this evening. I'm a GP in Melbourne and a member of the Immunisation Coalition. I acknowledge the traditional custodians of the various lands on which we work and welcome all Aboriginal and Torres Strait Islander people who may be participating in the webinar. I pay my respects to elders past, present and emerging, and I celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and waters of Australia. Presenting this evening's session is Angela Newbound, who will be speaking for around 40 minutes. This should leave us with plenty of time to answer questions and to discuss comments. Please type in your questions via the Q&A button, not the chat box, at any time during the session. You'll find the Q&A button, a square shape at the bottom of your screen. Angela will try to answer as many questions as possible, and for questions not answered, we will send responses to the questions over the next few days. This evening's presentation will be recorded. All participants will be on mute. At the end of this evening's webinar, you will receive an evaluation form. It'll take about 2 minutes to complete. Please do this so that we can continuously improve the quality of our education activities. Angela is a nurse, an immunisation education consultant, and a member of the Immunisation Coalition. She has been involved in immunisation programme delivery in South Australia since 2000, originally as an immunisation provider and then in programme coordinator roles within the divisions of general practice, the South Australian Health Immunisation Section, the Medicare Legal Local Network, and the Primary Health Network, and that was until December 2024. Angela continues to provide clinical advice and nurse education across a variety of platforms and is very passionate about vaccination and the role immunisers play in vaccinating. Angela, thank you for joining us and welcome.
Thank you very, very much, Andrew, and thank you for that very, very kind introduction. And now that everybody here tonight knows who I am and knows a little bit about my background, I'd be really interested to know where or who you all are. And so thank you, Anastasia. She's just launched a poll here. So just take a quick little minute there and just let me know whether you're a GP or a nurse, researcher, pharmacist, just so we can see who's actually joined us tonight. Perfect. Oh, fantastic. So about 80% of our attendees are nurses, midwives, or immunisation practitioners. We've got a little bit of smattering of others, some pharmacists there, and 10% are GPs or medical practitioners. So thank you very much, and certainly absolutely welcome. So we're going to just run through, a little bit about the burden of HPV-related cancers and disease, and certainly the benefits of HPV vaccination, which I'm sure that you're all very, very aware of. And we'll just have a quick recap on HPV vaccine and the dosing schedule, and a bit about the safety profile as well. So if we were to just do a little bit of an overview of HPV, we certainly know that HPV-associated lesions, including those skin and genital warts, have certainly been reported since ancient times. And so while the development of cervical cancer due to infection, wasn't really suspected until the early 19th century, it was, of course, Dr. George Papa Nicolau that observed those precancerous HPV-associated lesions in vaginal smears, and that obviously led eventually to the PAP screen test that we used to have. But it wasn't really until the 1970s that the role of HPV in cervical cancer was really postulated, and that was done by, of course, Professor Harold Van Housen, which is often called the father of HPV virology. We do know that there's more than 200 distinct types of HPV that have been identified, but most don't cause any concern. We certainly know that most people will be infected with at least one genital type of HPV at some time of their lives. And because this virus is so common, HPV has often been referred to as the common cold of sexual activity. But in about 90% of people, the immune system usually clears these genital HPV infections from the body within a year or two. However, sometimes those HPV infections are not successfully controlled by the immune system. And this persistent HPV infection and high-risk HPV types is the cause of cervical cancer and is associated with cancers of the vulva, vagina, mouth, throat, penis, and anus. We certainly know that human papillomavirus causes those papillomas, or more commonly known as warts. And, they are, those benign growths that really only form in certain types of tissue, although those tissues can be all over the body. So they can also form on the skin, of course, and in the surface of those moist tissue linings inside the body, such as the gut and the airway included. So we know that genital warts are caused by infection with HPV, mainly HPV types 6 and 11. And this infection is mostly diagnosed, of course, when warts are actually seen on physical examination. HPV genotypes differ in their preferred site of infection. So there is about 40 of those HPV types specifically that infect the anogenital tract. And the most oncogenic HPV type is actually HPV 16. But both HPV types 16 and 18 cause the majority of cervical cancers, and certainly are also responsible for many of those oral pharyngeal cancers and other anogenital cancers as well. And so, these cancers, and particularly cervical cancer, remains an absolute major health concern. And those low risk type 6 and 11, obviously just with the genital warts, but realistically, it's not a nice virus to have. Genital warts are very socially isolating for a lot of people if they have them. So, and as you're aware, of course, there are HPV tests that screen for cervical cancer, but there are no other HPV approved tests to find HPV in these other parts of the body. But what we do know is that HPV does require a breach in the epithelial surface to enter that basal epithelial cells through that endocytosis and cause infection. The evidence has suggested that HPV progresses successfully because it does not induce an immune system response for most of its life cycle. So that's really for a number of reasons. So firstly, you've got your keratinocytes, the target cell for HPV. They're less likely to incite that novel T cell response than other types of host cells. Secondly, HPV produces genes that suppress a part of the immune system. Thirdly, the immune system has better detection in the lower layers of the epithelium, but in those cells, HPV HPV produces, low levels of detectable elements such as capsid proteins. Fourthly, a HPV infection does not involve the bloodstream, which means the mechanisms for the immune system to detect an infection are limited. And finally, HPV infection does not cause host cells to lyse or die, which would typically induce that danger signal to our immune system. So there's a whole range of low risk types. So HPV types 6 and 11, which we've already talked about, 40, 42, 43, 44, 54, 61, 70, 72, 81 and 89, all low risk. The incubation time, so the time between becoming infected and developing symptoms for HPV is generally around 2 to 3 months, with a range of 1 to 20 months for genital warts. But it can take up to 10 years for high-risk HPV infection to develop into cancer. The infectious period, so the time which an infected person can infect others, really for HPV in general, it's unknown. But for genital warts, it's probably for at least as long as a visible wart exists. The problem with HPV infection, a lot of the time, if people don't have genital warts as their HPV infection, the infection itself doesn't cause any noticeable symptoms or health problems initially. Obviously, if it is a wart and it's visible, when they can look very different on different parts of the body too. They can be flat, they can be raised, they can form clusters like little cauliflowers. There's certainly subclinical infection, where there are no signs and symptoms, but where HPV is actually found inside the skin cells, and therefore it's still able to spread to others. Once again, no approved screening test for HPV in males at all. Obviously, if men are concerned or have any questions, they should be coming and seeing you, their healthcare professional. So, these genital warts particularly, like I said, very embarrassing, and, a lot of people really have, some issues with that. So we know that there's also some high-risk types of HPV, which obviously include types 16 and 18, which I spoke about earlier. And these can certainly take longer to clear from the body. And in some people, infection with these HPV types just remains for a really long time. And therefore, they're at higher risk of developing those significant cell changes or dysplasia, which can obviously progress to invasive cancer if it's not detected and treated in time. It's generally rare, really, for a HPV infection to lead to cervical cancer, but certainly if it does, there is a fairly long time period from when they first acquired that particular infection to when it's showing up. As you know, in December 2017, the cervical screening test, or the PAP, replaced the PAP test in screening for cervical cancer. Like I said before, the PAP test used to look for those cell changes in the cervix, whereas the cervical screening test looks for HPV, which can lead to the cell changes in the cervix. So those cervical screening checks are recommended every 5 years for women and for people that have a cervix, and they're aged between 25 and 74 years of age. And it's been shown to be highly successful in that early diagnosis and treatment. So at the point when abnormal cells in the cervix bind together and form tumours, cervical cancer symptoms can, may become apparent then. And those most common signs really include all of these. So the vaginal bleeding that occurs between the normal menstrual cycle or after menopause, vaginal discharge changes, menstrual periods may be a lot heavier or last longer than usual. Vaginal pain or bleeding during sexual intercourse, or if somebody's having a pelvic examination, maybe pain in the lower back or pelvic region, painful urination and urinary frequency or urgency, leg swelling. But because many cervical cancer symptoms are also associated with other, less serious conditions such as infection, women may not seek that early medical advice. So if women are coming to you with some concerns, then perhaps listen to them, because they're probably coming to you a little bit later than what they should. So HPV transmitted from person to person, of course, through skin to skin contact, mostly during oral, vaginal or anal sex. And a person with HPV can pass the infection to someone even when they don't have any signs or symptoms themselves. So anyone really that is sexually active can get HPV, even if they have had sexual activity with only one person and they've only had it once. But certainly the risk of acquiring a HPV infection has been shown to increase with the number of sexual partners each individual has. So we do know that there is a condition called recurrent respiratory papillomatosis, which can really occur at different stages in life. And the juvenile onset form is something that affects children on average at around about 4 years of age, and it's thought to be caused by the transmission of HPV virus from the mother with a genital tract HPV 6 or 11, so that genital wart infection, getting that passed to the infant during the birth process. So this is a rare disease, though. And even if the mother has active genital warts, the risk of the child developing RRP is very, very low. The Australian STI management guidelines for the use in primary care actually state that pregnant people can undergo a normal vaginal delivery as the risk of transmission to the baby is exceptionally low. So, certainly over the years, there may have been some obstetricians that have perhaps suggested cesarean section delivery just to reduce the risk to the baby. It's a discussion that you need to have, but certainly the guidelines are saying that the risk is still very, very low. And we don't really fully understand HPV transmission in RRP. However, there is potentially a slightly more risk of a vaginal delivery than there is if it's a cesarean section. But really, it depends on the cesarean section and whether the membranes were ruptured prior or only during the cesarean section. So, but it's a rare disease, but obviously very, very distressing disease because, of course, these warts grow in the baby's respiratory tract, and they're very, very difficult to treat. So the baby can quite often show signs of, or the child can be showing signs of hoarseness, might have a quiet or a weak cry, and obviously in severe instances there could be respiratory airway obstruction. Like I said, super common. Most people are going to get it if they're sexually active, and obviously if they don't get vaccinated. And the most common age for young people in Australia to have that first experience of sexual intercourse is around about 16 or 17 years old. And this really strengthens the importance and the reason that we are wanting HPV vaccine to be offered in high school to children in year 7. So they're technically around about 12, 13 years of age, hoping to catch them before they start having any of these sexual encounters, which are going to give them a risk of HPV, because we know that HPV vaccine works best when the person receiving the vaccine is completely HPV naive, so has never had a HPV infection. So hopefully in year 7, we're catching these children young enough. There's lots of risk factors, and they can be biologically based risk factors. The high rate of HPV prevalence amongst HIV-infected women is really thought to be due to that that compromised immune system. It just enables that viral persistence of HPV and increasing the possibility of contracting infections from multiple HPV genotypes. You know, obviously, age of the first sexual intercourse in some studies hasn't been related to HPV risk, but in other studies it has been. So we would certainly, you know, want young people to be seriously thinking about, you know, engaging in those sorts of activities. Age is actually an intrinsic host factor that really merits some extra attention, because it's one of the few biologically based factors that is associated with the risk of acquiring HPV infection. So age is, they say, also associated with the risk of viral persistence. And so as age increases, so does that possibility that a given HPV high risk HPV infection will persist. The relationship is suggested to be due to, you know, waning immune effects or characteristics of the virus itself, although the exact relationship between age and infection and viral persistence is really still yet to be determined. So genetic polymorphism is where there's an alteration in DNA sequence, and usually does not directly cause a disease, but rather it may serve as a predisposing factor. So lots of biological reasons, but there's also behaviour reasons as well, of course. So we know that several studies have examined the risk for genital HPV infection, particularly with those HPV types, you know, the number of sexual partners, having a new partner, and what that partner's sexual history is. That high risk sexual behaviour is also the main risk factor associated with that acquisition and persistence of HPV infection and the development of HPV-related cancers. There is some international data that show prevalence is high even in young women who are with their first partner and are monogamous. There's HPV infection rates of 30% within the first year of becoming sexually active, and still 48% within 3 years. Studies have shown, believe it or not, that cigarette smoking is also associated with the HPV load, HPV prevalence, incidence, and persistence. So if you've got any one out there that is smoking cigarettes, then this is another reason perhaps for them to think about giving it up. So there was a little bit of a chat around what happens with vaping. So there has been a little bit of published data on that. And in the Journal of Allergy and Clinical Immunology, they found there is a significant dysfunction in neutrophils, which was associated with changes in cell surface markers involved in environment sensing and adhesion in those who use e-cigarettes and vapes. So even e-cigarettes and vapes are not a safe option. So try and get these young people away from cigarette smoke and or cigarette smoking, e-cigarettes and also vaping. So worldwide, cervical cancer is the fourth most common cancer affecting women, ranking fourth for both incidence and mortality. However, its burden is not equal globally. Cervical cancer incidence is above 25 new cases per 100,000 women in some countries, compared with a relatively low incidence of 6 new cases per 100,000 women of all ages in Australia. So we are doing very well here in Australia. We have got good screening. We have got that early diagnosis. We've got early treatments. We've got a good health care system, even though we all very often complain about it. But when you compare what other countries have, we are exceptionally fortunate. Australia has one of the world's lowest rates of cervical cancer mortality. But in 2023, there were 265 deaths from cervical cancer in Australia, and realistically, that is 265 deaths too many. Cervical cancer is one of the most preventable and treatable forms of cancer, but that continued participation in that national cervical screening program, as well as the vaccination of girls and boys against HPV through that national HPV immunisation program, is absolutely vital to ensure that elimination of cervical cancer as a public health problem can be achieved. There's currently, one vaccine that's used, and that's Gardasil 9. It is a single dose now. You may remember when it was first used, it came out as 3 doses. Now in the general population, it's a single dose. It's available in the school immunisation program for girls and boys in year 7. Obviously, there is some demand for this vaccine after people turn 26 years of age. Once they've had that 26th birthday, they're no longer able to receive that single dose for free. So that means that they also will need to have a 3-dose schedule, which we'll be talking about. But, certainly talk to these young people before they turn 26. If they have not had a dose, now is the time to make the decision to have it, because, this isn't a cheap vaccine. So if they turn 26 and they need 3 doses, they're going to be up for about $220 to $260 per dose. So they may as well just jump in now and have a single dose for free. While it's being offered in the school program, according to the annual immunisation coverage report for 2024, I haven't seen the report for 2025 yet, 71.8% of girls and 67.8% of boys turning 13 years of age in 2024 had received at least 1 dose of HPV vaccine by the 31st of December 2024. So this coverage rate is really disappointing. And, we all healthcare professionals need to absolutely make an effort to make sure that parents are educated on why this vaccine needs to be given to these kids in year 7. It's just such an important vaccine. And I think perhaps there's many layers of complexity with the school program. There are barriers at every point, but I think if we can try and get parents educated on signing those consent forms and saying yes to the vaccine, we'll make some headway. So we talked about that 3-dose schedule for people that have turned 26 years of age. But it's also a 3-dose schedule for anyone who is immunocompromised, and that is regardless of their age. They also should be receiving the 3 doses of HPV vaccine. So Margaret is 30 years of age and is requesting HPV vaccination. So what is the recommended schedule for a 3-dose HPV schedule? Let's see how you go, because I just gave you all the answers on those other slides. How did we go, Anastasia? Okay, well done. 79% got answer D. So that's 0, 2, and 6 months, and that is absolutely correct. Although there is no specified upper age limit for the or the interval limit for that 3rd dose of vaccine, it's certainly advisable to keep people on schedule if you possibly can. Obviously, in the immunisation handbook, it would actually say that if an immunisation schedule has commenced, you never recommence the schedule if they have exceeded those minimum intervals. It is only if there is no documentation that you can find to say that a schedule has started, that's when you would start again. So if this person has 2 doses and then they don't come back for 3 years, you just give them the 3rd dose when they do come back. So, but just never need to restart a schedule. Right, let's click over here. Right, okay. So who else should be vaccinated? Obviously. So studies have really demonstrated that men who have sex with men have a higher risk of repeated and persistent HPV infection and associated diseases such as genital warts and anal cancer. And that's at all ages and regardless of HIV status or other immunocompromising conditions. So patterns of HPV infection and disease in men who have sex with men are markedly different from those of heterosexual men and women. And men who have sex with men are also less likely, of course, to benefit from the herd protection attained from HPV vaccination of females. So HPV vaccine is recommended for men who have sex with men of any age who have not previously been vaccinated. Adults over 26 years of age who have been diagnosed with or have a history of HPV-related precancerous or cancerous lesions may be considered for vaccination because of their inability to clear and control HPV infection, noting vaccination protects against future infections and does not have any therapeutic benefits if the infection is already there. Obviously, chronic immunosuppression for various reasons is another important risk factor for those persistent infections with HPV and also for HPV-related disease. And because the immune response is likely to be lower in immunocompromised people than healthy people, that 3-dose schedule is recommended. And those significant immunocompromising conditions really include, that primary and secondary immunodeficiencies, HIV infection, any malignancies, organ transplantation, or significant immunosuppressive therapy. People with asplenia or hyposplenia can just receive a single dose. They do not fit that immunocompromised category where they need 3 doses, unless, of course, they are older than 26 years of age. So is routine HPV vaccination recommended for all adults 26 years and older? Let's see how you go. Okay. How did we go, Anastasia? We got a bit of an idea here. Yeah, absolutely. So 84% of you got it right. So it is A. So it's not routinely recommended for them, but certainly there are some adults that may benefit from HPV vaccination because antibodies prevent viral entry. Vaccination may still be of benefit for sexually active men and women by protecting themselves against any new infections with other vaccine preventable HPV types or reinfection with other vaccine preventable types that they've been previously not been exposed to. So there's certainly some considerations, certainly noting, of course, that all men who have sex with men, including those over 26 years of age, are recommended to receive those HPV vaccines. So, like I said, there is only Gardasil 9 now, so it protects against these 9 HPV types. So you can't get too confused with which vaccine to give when you're vaccinating someone against HPV disease. So who shouldn't have the vaccine? Obviously, an anaphylactic reaction to a previous dose of HPV vaccine or a component of the vaccine or to yeast is the absolute contraindication to further doses. And this really highlights the importance of completing that solid pre-vaccination checklist prior to vaccine administration, and certainly to have all of your staff trained in anaphylaxis recognition and management. Okay, HPV vaccines are not recommended for pregnant women because, let's see how we go. Is it a live virus? Is there just absence of evidence? Does it cause problems in the pregnancy or the baby? Or are they at high risk of anaphylaxis? Okay, let's see how we go, Anastasia. Yeah, okay, so 80%. Well done. So the answer is B. There is just the absence of evidence. Women who are inadvertently given a dose of HPV vaccine around the time of conception or during pregnancy should really just be reassured that there's just no evidence that suggests that vaccination, causes any harm. So there was a pooled analysis of women who became pregnant during clinical trials of the 2-valent as well as the 4-valent HPV vaccines, so those earlier vaccines, that overall there were no differences in pregnancy outcomes between the HPV vaccine recipients and the control vaccine, the controls. So, but just as a precaution, women who become pregnant after starting a HPV vaccination course, and if they require more than 1 dose, the recommendation is just to wait until the baby is born and then continue on with whatever doses they need. Okay, we mentioned cervical screening before. Despite the advances with HPV vaccine, it's still really essential that women and people with a cervix do have that cervical screening test every 5 years, if they've ever been sexually active. Obviously there's the great idea now that it can be a self-collection of a vaginal sample using a simple swab, or they can have it collected, via a clinician going and seeing their GP. But certainly the self-sampling HPV has been proven worldwide to be accurate for HPV detection. And then it's can actually increase coverage for cervical cancer screening because it is easy to use, it's convenient, people can do it in their privacy of their home. It's a lot less embarrassing for a lot of women and a lot less painful. So how effective is all of this? Well, an article's just been published that suggests HPV vaccine is beating cervical cancer. A US study shows that nationally cervical cancer rates in women have dropped about 27% since HPV vaccination was introduced. In some states, rates have fallen by more than half. There's just been a large study that was published in the New England Journal of Medicine, which analysed data from Sweden's national vaccination program following more than 1.6 million girls and women over 11 years. There's found to be that the protection offered by HPV vaccine, does not fade. There's no evidence that it's fading. Those that were vaccinated before the age of 17 had around a 79% lower risk of invasive cervical cancer. So really together, these studies show that where HPV vaccination rates are high, cervical cancer declines faster. But of course, there's unequal coverage in some regions, which is really disappointing. But it just tells us that the HPV vaccine is doing exactly what it is designed to do, and that's preventing cancer, cervical cancer, and that continuing protection for many years. So, there was certainly some studies, of course, that were done in regards to a single dose of HPV vaccine that was shown to be just as effective, realistically, than a 3-dose. So that was a Kenyan study that was done. Multiple other studies have also been done that have proven that this vaccine is highly immunogenic, and it is actually doing the job that it's designed to do. So 2024, the cervical cancer detection rate was very low here in Australia for participants between the 25 and 29-year-old age range. The cervical cancer detection rate was between about 0.4 and 0.7 participants with cervical cancer detected by histology per 1,000 participants that were screened. So we just need to keep vaccination rates high if we're going to succeed in preventing cervical cancer in women and cancers in men as well. It's a very well tolerated vaccine, very, very similar adverse event profile as other vaccines. So, you just reassure people that, yeah, they may feel a bit off for a day or so, but they're pretty short-lived and nothing really to worry about. Of course, there's all of the myths that are out there. People that don't believe in vaccines will try and find anything negative or controversial or false or misleading or whatever you like to call it. But, despite some controversy in, social media and in those certain population, studies have shown that there's absolutely no impact on human fertility following HPV vaccine. There were some websites that were reporting really disturbing claims that one of the ingredients in the vaccine, which is polysorbate 80, caused infertility in rats. And this was really based on one study of newborn rats weighing about 10 grams that were given extremely large doses, about between 20 and 200 times the amount that is in Gardasil, and that was injected into their abdomen. So there's just no evidence. Now, just got to remember that polysorbate 80 is used as an emulsifier. It's found in numerous medications. It's, not just in vaccines. It's commonly used as a food additive, and it's used in cosmetics. And if you're eating ice cream, you're eating polysorbate 80 because it is very commonly used in the manufacture of ice cream, for that destabilization of the fat emulsion. And that makes the ice cream nice and smooth and easier to handle, and it sticks together on top of your cone. Without polysorbate 80, it would just be falling all over your cone. So, they tend to make a bit of a racket about things that aren't, really important. So we certainly, we'll just go back to aluminium. So adjuvants, of course, have been used in vaccines for a long time. They're not linked to autoimmune disease, and there's plenty of evidence about that as well. Analysis of several clinical trials involving more than 20,000 participants found that overall portion of participants who reported new onset autoimmune conditions was really of similar background to those who did not get the vaccine. Also, no evidence here either for premature ovarian failure or postural tachycardia syndrome or complex regional pain syndrome. There's just no evidence to support that HPV vaccine triggers any of those. So just really quickly, before we go to questions, I've allowed some time for that. Look, very common sexually transmitted infection in both males and females. Obviously, HPVs can cause cancer of cervix, vagina, vulva, penis, anus, head and neck. There's different types of HPV. There are some that are certainly cancer causing, type 16 and 18 the cause of most of those cancers. It's a single dose funded on the NIP for those boys and girls aged 12 or 13 in the Year 7 program. It is free up until the 26th birthday. It's just that single dose. It's well tolerated and safe. But, just make sure that you are checking the Australian Immunisation Register at every encounter, opportunistically immunising these people if you cannot see evidence that they have had a dose, and please ensure that those doses are reported to the AIR. So thank you very much, and thank you, Andrew. I'll stop sharing.
And thank you, Angela. Thank you very much for a comprehensive presentation on HPV disease and on its prevention. Informative, insightful, evidence-based, and practical too. So thank you. We have got 16 questions and we've got about 16. We're not going to get through all the questions in that time. And there is quite a lot of overlap between the questions, particularly around indications, schedules, and funding. But as we said earlier, if the questions aren't answered, we will address them later and provide them subsequently. But let me start with breastfeeding. You talked about pregnancy. Is the vaccine safe in women who are breastfeeding?
Yes, they can have it while they're breastfeeding. Absolutely. And look, to be honest, it's been proven to be safe in pregnancy. Certainly on those clinical trials, there was no evidence of anything going wrong with the pregnancy. It didn't increase, any congenital abnormalities or risk to the pregnancy. But just as a precaution, because of the lack of evidence, they suggest not to use the vaccine in pregnancy, but certainly as soon as the baby is born, if the mum's breastfeeding, they can go ahead.
And on the other side of pregnancy, what about preconception? So if a woman comes to see you and she says she's thinking of getting pregnant, what about HPV vaccine in that situation?
Yeah, absolutely. And because it's not a live virus vaccine, there's no reason to have an interval of, having the vaccine and then, conceiving. So no, they can go ahead and just be vaccinated at any stage up until, they want to start trying and get pregnant.
Excellent, thank you. Question now about, I suppose, incubation and dormant. Can HPV remain dormant in the body and then recur? In other words, can it do a zoster? And how long incubation period? Have we got any idea around that, Angela?
Yeah, look, incubation period, that sort of, it depends on the virus itself, as they were saying for the genital warts, it could be up to sort of, 20 months, maybe 2 years before anything will actually start showing. Some HPV infections might show a little bit earlier, but certainly those really serious cancer causing ones, they can sort of just remain in the background, Andrew, for maybe 10 years. They can be they just tend to be able to hide from the immune system because of the way they infect the cells.
So coming back again to the vaccines themselves, and as I say, this is a question around scheduling and indications. Why 3 doses for 26-year-olds, but only 1 dose for a 25-year-old at catch-up? So what's magical about 26?
It's called a line in the sand is pretty much what it is. And the older you get, the more likely it is that you've had sexual activity. You're more likely to have had these HPV infections at some stage of your life. And like I said before, giving the vaccine, if you've already had those HPV infections, the vaccine's not going to stop any progression of disease or anything like that. So, I think we need to be really thankful that the government has drawn a line in the sand at 20, before turning 26, because realistically, by then we know that people have probably been sexually active for 10 years. By looking at the data, they're saying that kids are 16, 17 are debuting with their sexual activity. So I think we're pretty lucky that we've got it. And hopefully those people, even though they've probably had HPV infections, Andrew, that they probably haven't had all 9 of those serotypes that are in the vaccine. So the vaccine's still going to be at least protecting them from those other serotypes. Yeah.
Thank you, Angela. Men who have sex with men, you made it, you emphasized the importance of the vaccination for men who have sex with men. Do you think that'll ever be funded under the National Immunisation Programme?
Look, wouldn't that be lovely if it was? I think you will find that I know that there are some sexual health clinics where they see these individuals quite often for their sexual health, and I am aware that they can often just give the vaccine, and they are not asking the people to pay for it. But I think that may depend on clinics, and it may also depend on state health departments and whether they are funding the vaccine for those clinics. So it would be worthwhile for any practitioner to contact their state health department, state or territory health department, just to ask, are they funding the vaccine for sexual health clinics?
Yeah, that's a very useful answer. Thank you, Angela. Going back to schedules and ages. So under the age of 26, is the 3-dose schedule funded for the persons who are immunocompromised?
Yes, it is. All 3 doses. Yes, absolutely. Yes.
Yeah. And the single dose of the, and I'll call it a nonavalent virus, I've learned that word recently, is it funded for those between the age of 20 and 26?
Yes, it's funded all the way up to the 26th birthday. Once they've had that birthday and blown out those candles, that's not funded.
I've got an interesting question around respiratory papillomatosis, and it's interesting. If a practitioner is doing diathermy on a wart, what is the risk of the operator, that's to say the practitioner, developing respiratory papillomatosis from the aerosol from the diathermy?
Yeah, look, I think probably above my pay grade for the answer, but I would be I would be saying that the risk would be exceptionally low. To be honest, in that particular procedure, I think for most of those types of procedures where there is any type of particle floating into the air because of the procedure, you should be wearing a mask anyway. So I think my personal, I don't know, but I would say it would probably be low risk, but there would be some specialists out there that would be better qualified.
Okay. And Angela, here's a clinical enigma. So a person with a cervix who's been in a monogamous relationship for over 20 years and has not had known to have had any HB infections in that lifetime, has a cervical screening test and is now positive for HPV. How do we explain that to the person with the cervix?
Yeah, look, and it's a bit of it's a hard thing really, isn't it? Because, quite often it will depend on what their partner has also been up to. Has their partner been perhaps doing something that they shouldn't be doing and bringing it home? Um, but, certainly, as we know, that HPV, infection can be acquired at any time. And, I think in, one of my slides there that, I even spoke about people that even if they are monogamous, etc., there are certainly cases of HPV infection that
Mm,
occur.
yeah. So if a person, so I'll say male or female, man or woman, had had the quadrivalent vaccine when they were in year 7, and later over the age of 26, they commence activity in high risk sex. Should they receive further doses?
Look, at this stage, there's no recommendation for people that have previously received the HPV, 4-valent, the original Gardasil or Gardasil 7, to come back and have another dose of Gardasil 9. There's no recommendation for that at all.
Mm. And here's a question which might relate to one of your other roles in immunization programs. One of the attendees has commented on anecdotal stories from school health nurses working in private religious affiliated schools that there's been pushback against vaccinations. And the question is, what advice can we give to these schools in order to advocate for vaccination for young people?
Yeah, look, this is a really tricky space, Andrew, and we've been faced with it for many years, since the program vaccinating in schools started in 2007. We were vaccinating girls, and we've had some pushback from these private schools, these religious schools. Um, that they have the right to say, look, no, we're not offering vaccine on site, but if the students want to go off and seek it privately at a local council clinic or their GP or whatever, well, that's up to them. But it's not helpful. It's not really pushing the message out there. So it really is something that needs to come from a government level, through Department of Health to Department of Education. The Department of Education still has an overarch over those private schools. So it's something that really needs to be addressed, I think, at a much, much higher level, because the poor clinician who's trying their best to get these people vaccinated, if they can't get in the gate, they can't get in the gate. And so therefore, there's much higher people that need to be involved in some discussion.
And those are very pertinent comments in regard to your comment about vaccination coverage, which I was quite shocked to realize was as low
Yeah,
as in the 60,
yeah,
70,
yeah.
70%.
Mm,
Well, probably just one final question.
sure.
You identified several high risk behaviors, and I was surprised about the cigarettes and the vaping and the alcohol.
Mm.
I mean, no young people actually practice any of those behaviors, do they? But this is a question about are males more at risk from contact than females?
Um, I haven't seen any uh, any data that supports that. There may be data out there that says yes or no. Um, I think data is very much shifting. I think we are now, because we've got, a lot of um, you know, different people in our community now that are having different sexual practices than what has happened, perhaps in the previous years. So I think we're going to see a big shift in who's getting infected and how it's getting passed on, to be honest. But I've not really seen that, yes, it's a female's problem and it's a male's problem. It's a both problem. Yeah.
Thank you, Angela. So, look, we've reached the close of the this evening's session. I might put you on the spot, Angela, and ask: is there a one-liner take-home message for everyone who's in the webinar this evening?
absolutely ask every patient every time. And if you check the AIR, there's no record of a HPV vaccine given. They are eligible to receive a dose. Please have the conversation with them, and just opportunistically immunise.
Fabulous. Thank you, Angela. That was a long one line, but it was a fantastic.
It was a very long one, Niall. I'll take every inch I can get, Andrew.
Well done. So there have been questions that haven't been answered. We will be answering those, and they will be provided. The answers will be provided to you. So thank you.
Okay.
Thank you, Angela, for, as I say, a fabulous presentation. Very engaging, very, as I say, informative and insightful, and ultimately very practical, as indicated in your take-home message. So thank you very much, Angela. But thank you to our audience for taking part, for your engagement, and for your questions. So many, many thanks. Our next webinar is the 2026 Influenza webinar. It's on Wednesday, the 8th of April at 6 o'clock. And that's Australian Eastern Standard Time. So daylight savings has gone by then. And it will be presented by Angela Newband. So registration details can be found on the Immunisation Coalition website and in the weekly newsletter. So that's it from me. Thank you for your participation. I hope to see you all again next month. Good evening. Stay safe and stay well. Thank you.
Thank you.